racism, sexism, ageism. These are but three of the many issues we confront today in the Canadian society. This evening, St. Hilda's continues with our series of forums exploring the challenges of ageism, and we are pleased to acknowledge the support of the Government of Canada in its funding of these forums, and delighted to welcome the viewers of Rogers Broadcasting who are joining us for this event. As has been referenced by the National Seniors Council in its many fine and recent studies, in little more than 15 years, over 1 in 4 Canadians will be 65 years of age or older. Consider the implications for our labor force, legal and healthcare systems, social and physical infrastructure, intergenerational relations, and public policy, to identify but a few of the many areas that will be deeply impacted by this impending demographic reality. Good evening, I'm Canon Derwin Shea, Chairman of St. Hilda's Towers in Toronto, and on behalf of the Board of Directors of St. Hilda's Towers and the Wardens of St. Hilda's Anglican Church, it gives me great pleasure to welcome our audience and viewers to this second of our 4-part series of special forums we will continue to host throughout the year addressing the issue of ageism in our communities. This evening, we continue our focus on the barriers that contribute to or sustain attitudes and actions that foster ageism. We are delighted to welcome tonight's distinguished guest host, Mr. Dave Trafford, News Director for radio station CFRB and host of Newstalk 1010 Radio. Mr. Trafford will host the panel's discussion and the question period that follows. This evening, our panel reflects considerable experience appropriate to our topic at hand. Joining Mr. Trafford, we are honored to welcome Dr. Harold Becker, Medical Director of St. Hilda's Towers. His association with this unique and caring, independent, and assisted living facility has been a constant from the very beginning. With Dr. Becker, we welcome to the panel Marilyn White-Campbell, geriatric addiction specialist with community outreach programs in addictions. And with her, we welcome Dr. Rosemary Meyer, Director of Psychogeriatric Services at St. Joseph Health Centre and Assistant Professor in the Departments of Psychiatry and Public Health Sciences at the University of Toronto. With her, we welcome a special friend of St. Hilda's, Dr. Maria Zozita, who is the Chief of Geriatric Medicine and Medical Services Director of the Regional Geriatric Program of St. Michael's Hospital in Toronto. And we also welcome Constantine James Shishis, who is the pharmacist owner of Lefko Pharmacy, who also specializes in medication management for seniors. A distinguished panel indeed, bringing to the discussion considerable training and a broad range of experience. We appreciate the interest and effort each member of the panel and its host has made to join us as we explore another aspect in the challenging issue of ageism. Now, Mr. Trafford, I turn this forum over to your very capable leadership. Please join with me in welcoming Dave Trafford.
Well, I appreciate the introduction, but we should note that the first forum that they had here at St. Hilda's was hosted by Steve Paikin. He was the TV guy, they didn't do TV. I'm the radio guy, we're doing TV. Steve Paikin's the TV guy, he's the smart guy. You guys got stuck with the radio guy tonight. So, after all of the credentials that are here on the panel, and they are all the smart folks here, and then they're here to help us understand better what we're going to talk about tonight. And these are the addiction issues that seemingly face seniors and probably is much of an issue for the caregivers as well. So we need to actually deal with that as we go through the evening first. So I'm just the dumb guy in the room, so I am going to ask the questions. And I suspect there are many of you here who have better questions and more experienced questions than I. So as we go, I would be really appreciative if you'd take the time to sort of, write down the questions, because there will be a Q&A session. And if we didn't get to what you want to get to, there will be an opportunity for you folks to ask those questions. So what I'd like to do here is maybe go through the panel, and rather than having you just kind of give me 5 minutes or 3 minutes of your expertise, I'm going to frame it. And I really want to kind of start this because I think for most people we're going to look at addiction just from the street level and the way we have to deal with either our grandparents or our parents as kids who are, living with this now and they have this experience in our lives, or how seniors who are living here at St. Hilda's are going to deal with it. And I think one of the questions that I would like to start with and bring your expertise to sort of have the opening statement. If we look at addiction for seniors, is this somewhere between a matter of ignorance and neglect? And I don't say that disrespectfully, but I think at some level, that's really going to be the heart of what we talk about here today, because this is about advocacy and it's about awareness. Perhaps Dr. Zorzito, you can start us off.
Okay, well, I am a medical doctor, a geriatrician, and I work in a large downtown community hospital, and certainly a lot of the seniors that present to us have some form of addiction, and we see them when the consequences of that addiction presents. So, I mean, just to frame it, what do we really mean when we say an addiction? It's an irresistible urge to take a substance like alcohol or drugs, or to undertake some kind of activity, even though you know this activity is bad for you. Bad psychologically, or bad in a health sense, or bad to the relationships that you may have, your children, grandchildren, and neighbors. So, is this a common problem? I say it's gone largely under the radar. It's not easy to recognize from the point of view of the physician unless we have training in this area, because a lot of seniors have a lot of other medical problems and they take a lot of very legitimate medications. So how do you distinguish an addiction kind of problem from a real legitimate problem? I should say, it's the wrong word, I think. They're all legitimate problems, but I mean a more physical problem, or related to a medication side effect.
Can I just ask you, let's go to the pharmacist here, because that kind of ties into where you're going to bring us, I would think, and it's not just good enough to talk about how the medication is going to treat the symptom. We really are talking about how the medication, as Dr. Zorzito points out, is affecting the individual too in a much broader way.
Yes, and from the pharmacist standpoint, we're able to. We obviously have a tracking system with our computers, and really where I come in is to try and recognize patterns of use or overuse, even though the pharmacist obviously is tracking a lot of different things. But when we're talking about, I'd like to call it more, rather than addiction, maybe more sort of a pattern of overuse of certain classes of medication, that it's a valuable tool that we have to recognize when the pattern starts to get sort of out of control, and our job is to then try to come up with some sort of a solution, if you will. The way that I look at the pharmacist's role is more of a medication manager, and we have a lot of tools that helps physicians, helps family members, and helps the senior themselves control the use of these medications. And I'm talking specifically about like bubble packaging, weekly management of medications in a controlled way, so that, a lot of times somebody might be presented with a bottle in front of them, and there could be legitimate issues with regards to sleep, with regards to pain. And a lot of the times it is the easy solution to maybe take an extra tablet or an extra couple tablets, and to get into a pattern of taking extra more often than not. And I think that our role, especially with seniors and with families that are trying to help their elderly parents, that we can play a very important role in coming up with these sort of management systems to help the controlled use of these medications and the monitoring of the use of the medications.
Dr. Meyer, we kind of bridge the two then, because if we start talking about the addiction side of things, the pharmacy is trying to manage this as best we can. We put the systems in place, but from your experience, somewhere in between there is dependency. There is a need to begin with for that medication. There then becomes dependency. If we're not careful, we get to an addiction, and we'll get into that more deeply. But I think there's also the support system that's in place. It's not just the patient often that you're dealing with. It's the family or the caregiver around them that has to be just as aware of what's going on as perhaps the doctor and the pharmacist in this case.
Yes. Well, I think when you say dependence, that really is more the issue. We do obviously, and I'm in psychiatry, and I work also in a very busy community hospital with an extremely busy emergency room, that we do see, and perhaps increasingly we'll see people who do have what we might call addiction, but much more often people are becoming, and I would say, used to medication. This very afternoon I had a very cognitively aware senior citizen who has worked as an RN, who indeed has attended one of Marilyn's courses, and discovered that she was really overusing something which is an over-the-counter medication. She doesn't need a prescription for it. It was acetaminophen or Tylenol. And what was she taking it for? What did she hope it would help her with? She said, I just have got used to taking it. I've always taken it, as long as I can remember, at bedtime. So I think it's getting used to, and that is a less loaded word than addiction, or even dependence. But I think I must point out, as well as prescribed medication, people are taking other medications. They're taking over-the-counter medication that you don't need prescriptions for. They're taking, especially in Toronto, remedies that come from different cultures, and they're mixing them. People on the Danforth are not just taking remedies that their great-grandmothers would recommend, but also Chinese herbs. People in the Portuguese area are taking other medications too. So we have a very multicultural mix of over-the-counter and remedies. We also have over-the-fence, and this is when neighbors share medication. Something really helped my knees or helped my arthritis. Do try some. And we also
And they think they're helping by doing that.
They're helping, yes.
Sure.
And I think also we find that benzodiazepines are perhaps one of the prescribed medications that people do have a physiological or kind of physical dependence on as well. And they have an increasingly unwanted effect as we get older, because as we get older, our bodies are changing, the way that our kidneys work, the way our liver handles medications really change. So the same amount of medication or remedies that we took when we were younger, in our 50s or 60s even, certainly have a different effect as we get older. Marilyn may talk about the effect of alcohol, which is particularly striking, and actually women tend to have more troubles because their livers work slightly differently than men's. It's not equal opportunity. So we have over-the-counter, over-the-fence. And then what I also find is that sometimes the sharing within a family or between a couple, and I remember doing a home visit with the regional geriatric program some years ago to see the wife of a couple, and the husband keeled over while we were in the kitchen. And it turned out that he had been taking her medication. So we have to be very careful and to ask questions, but also hope that everyone will tell us what they're actually taking, not just what they're prescribed.
So now that you have thoroughly complicated the matter even more than we had hoped for, because you illustrate, I think the point, Marilyn White Campbell, how do you sort of pick through all those worms in a can and kind of, you have to be specially aware to be ahead of the curve in terms of dealing with some of these cases that you would see.
I guess the question that maybe we're looking at is when do you know somebody really has a problem? When do you know when it becomes an addiction? And because there's, people do get prescribed medications legitimately, but then may become inadvertently addicted, or they're prescribed the medication and perhaps the young grandchildren, they're prescribed medication for pain. And opiates, for instance, the OxyContin is the one sort of drug that's been mentioned in the news a lot lately. And perhaps the grandkids get hold of grandmother's prescription medication, or even older adults who are prescribed psychiatric medications and combine them with alcohol. So the addiction comes into play when it becomes a problem. So if you're having a couple of drinks a night, or you're taking medications for pain and you're managing it responsibly, then it's not a problem. It becomes a problem when it interferes with your health, with your family, your social, sort of occupational functioning. And generally we see people in treatment when it becomes a problem in terms of their health issues and how it affects their day-to-day functioning. And we see folks with usually more than one issue coming into treatment. They may be coming into treatment because of their substance use, but also other problem areas. So, and oftentimes they may have developed a tolerance to alcohol, as Dr. Meyer had mentioned. Tolerance in later life, it can happen very quickly, and particularly for women. Women can run into problems much more sort of at a higher level than men, but the tolerance piece really can potentially, that's where you see people really starting to fail. They become dependent on the substance and tolerant in the sense that they have to have more and more of the substance in order to get the same effect. So they may be using prescription medications quite legitimately, but also combining them with alcohol and having other issues, other mental health issues or social issues within the family. So those are the folks that we're seeing in treatment these days.
And I want to come back to that, because it's going to be an important part of how we deal with that in terms of awareness, I think, and hopefully use the tools as a preventative measure to be able to say, this is what I recognize either in myself or someone in the family. But Dr. Becker, I left you to last for a reason, and I think just we were talking at dinner about how St. Hilda's is not about warehousing people. It is about making this is their home. This is where they live. But part of their routine here is to ensure that their health is taken care of, that their medications are properly administered, and that's an important part of why people live here. But I asked the question off the top, how much of it sort of lingers, that addiction issue, between ignorance and neglect? And at some point, I think it kind of falls in between, doesn't it?
Yeah, that was an excellent starting question, Dave. The elephant in the room is that it takes two to tango. And nobody here has yet mentioned the prescriber of the addicting, quote, medication. I'm trained as a family physician. I'm a primary care physician. I see addiction from the beginning. The joke in practice is that when a new doctor goes into practice, his first patients are usually drug-seeking individuals, usually young people, drug addicts looking for to trick the young, naive doctor into prescribing narcotics because they have too much pain, etc. So there's the physician who is in this equation that is a key part of abuse of medication. That doesn't exist when we're dealing with smokers or we're dealing with alcoholism, and those are serious problems, but we haven't even talked about that really very much. A quick anecdotal story, very appropriate to the topic. Last week, a family member, a distant family member of mine, we visited her in her long-term care facility, and she had been demonstrating some confusion. She was only 91 and had not been confused the months before. And I went down to the nurse's station. I don't usually do this, I just visit, but I decided to go down and see what was going on. She was getting confused in the evening, And that's certainly raised a flag for me of some kind of sedative medication. This woman, I did not know, was on 17 different drugs. She was on something for blood pressure, 3 different drugs, which was legitimate. She was on something for heartburn because she was having some regurgitation and reflux. She was on calcium. She was on a diuretic for swelling. She was on an inhaler because she was having some cough. And she was on morphine sulfate. And why was she on morphine? Because the reason she went to the long-term care facility was that she had broken her hip and had been in some pain when she left hospital. And the morphine that was prescribed when she was discharged from hospital was continued indefinitely by the physician in the home. And whenever she came to see him, apparently he'd say, "How you doing?" She said, "Well, I still have some pain," so he continued the morphine. And one day she apparently came to him and said, "I'm having trouble sleeping." So there goes the benzodiazepines, the Valium, Zopiclone actually she was given. And a week later, apparently she came back and said, when he asked her how her sleeping was, or perhaps it was a month later because there wasn't a lot of follow-up, and she said, "Well, I'm still not sleeping very well." So he doubled the dose. And that's what brought her to our attention. So, I mean, she did not know of any of this stuff. The nurses would come and give her her pills at breakfast and at dinner. And then they would come to her apartment at night and give her her sleeping pill and her morphine. So she had nothing to do with that other than the fact that she was taking the pills. I think that's just appalling. There's an awful lot of that going on.
And a key part of all of this, I think, there will be that triangle of responsibility. Given that the patient is going to have to be, to some degree, always an advocate for themselves, we're finding that families step in and become an advocate. Who should be having the conversation with that doctor? And I understand that there's an issue that the patient must do that. But if that woman's son or daughter or sister or husband was involved in that conversation, does that help it or does that complicate it more often than not?
When I teach medical students, I talk to them about when we first start the year, and I teach a first year course, we start the year when where have you come from, what's your background, and the students today all have master's degrees, PhDs, and engineering degrees. It's quite amazing. And I say to them, that's nice, and I'm impressed, but I am, but you're all going to come out hot dogs. You go in as your own ingredient, but you're going to come out a hot dog because you all have to do the same thing. You have to prescribe the same, you have to go back a minute, you have to take the same history, you have to make the same diagnoses, you have to do the same tests, you have to be a clone of the medical profession as we train you. And you have no real control over that because if you're being trained properly, you're going to come out a hot dog. And so the answer to your question is we rely on medical education and licensure to ensure that docs who come online are well trained, and they are. They're very well trained. Then we go through specialty, and they're trained at subspecialty levels, and that's very impressive. And what happens after that is a bit of a crapshoot. I'm not that negative. I think 95% of doctors are very well trained and maintain their knowledge base and their prescribing and their awareness of things. And I don't know how you pick the other ones out.
Yeah, I guess once we get to a certain point, we can start to measure intention, and that becomes very nuanced, and it's hard to determine exactly how that's going to play into it. But you know, even when we start talking about systems, they are written down, they're great on the computer and the spreadsheet, but at some point making eye contact, and I know often someone will come to the pharmacist and say, here are the lists that I've got. Having that conversation is important.
Just to follow up on the question that you just asked Dr. Becker, also we have to recognize that a lot of these doctors that, for example, if we're talking about a facility like St. Hilda's or some sort of a nursing home or a retirement residence, that often there are few doctors, maybe there's one doctor for a whole facility, maybe there's a few doctors for a facility. They see a lot of patients, and seniors are on a lot of medications, and I can imagine that it's not an easy task to be able to go through a patient's list of medications and all of their medical issues, and to be able to keep track and to really give the time that might be necessary to manage their issues and their medications properly. And I think that the answer is that absolutely, if there are family members that are involved in their loved one's care, whereby they may even go into the appointment when their loved one sees the doctor, if the pharmacist is also, for example, what we do is we make sure that every resident of any facility that we service gets a 3-month medication review done by the doctor. It has to be assessed by the doctor. Every medication has to be looked at and has to be signed off on. When you factor all of these different angles, where you have family members that are involved, where you have reviews that are done on a regular basis, these are the beginnings of having some control and some way of managing everything, as opposed to just having Mrs. Smith go in and having a few questions asked and saying, yeah, I'm still having pain, and then just continuing the morphine, on an ongoing basis without really considering whether it's needed or not. I mean, those are the type of questions that do have to be posed, and sometimes I'm sure the physician needs that little extra maybe push to think of those questions, if it be by a family member, if it be by a review that the pharmacist has put in front of him or her, as opposed to maybe necessarily relying on just the information that the senior themselves might be able to provide.
Dr. Zorzita, we're getting a lot into a discussion here about the art of making sure that medications are properly managed beyond the science of medications that are properly prescribed.
Okay, so how do we do this?
Yes.
Okay, it's not an easy task. For example, when people will come to the office and they bring you the shopping bag, you don't know what's in the medicine chest at home or what was left out. And I spend the nurse in the office that works with me, she spends half of her time in the office calling up the pharmacy, looking on the drug benefit plan. It takes an enormous amount of time to accurately understand what a person has been prescribed, what they have purchased, let alone all those remedies that are on the Danforth, so to speak, that we don't know about, or in fact they're trading with their neighbors. If one aspirin is good, maybe Aleve is better on top of that, but in the long run you'll get into more problems that way. So how do we do it? We have those checks. We have the pharmacies who do have computer systems. We do try to encourage the families to bring in, and really, so we can actually count the pills that are in the vials, or try to get dosette systems or blister packing or some other way of checking what at least is prescribed, because some of the other things we will not know. And the issues that are really much more challenging is what is not prescribed. So for example, you can get nicotine and alcohol at the drop of a hat. And since everybody's given an anecdote, I think I will give mine. So there's this 86-year-old woman who lives alone in an apartment, and about 8 months ago she fell and she was on the floor for 5 days. So that resulted in a lot of injury. So she comes to the hospital, the acute medical problems, the bruises, the pain, the ulcers, and all the rest of it is managed. She goes off to rehabilitation for 2 months. And within a month of being home, she's back in the emergency room, a fall. And this time she wasn't quite on the floor for as long a period of time, because by this time she had one of those lifeline gadgets, and help came to her more quickly. Then it came to light from a relative of this person who was living alone that she was actually taking large amounts of alcohol, that there were empty bottles in the cupboard, and but by the time she came to the emergency room, you couldn't detect this alcohol. It just wasn't there. And the person herself was saying, no, I don't have a problem with this. So off she goes to rehabilitation again, and within 2 days of being home from rehabilitation, she's back in the emergency room with another serious fall, but again was rescued within a few hours of that fall. So now what can you do? This time there was alcohol in her system. Okay, and so you say, what's going on here? I mean, and you say, you're drinking too much alcohol. And she says, no, I'm not an alcoholic. That's not my problem.
Well, and but it's an important point. As far as she's concerned, it's not her problem. She's probably got other issues that she would recognize. Maybe, Marilyn White Campbell, here's somebody that can they can drink me under the table. They don't have a problem with alcohol. They're just doing fine. And we laugh about it, but that is one of those hidden things that we aren't really addressing. If this woman had fallen, 3 or 4 or 5 times, had to come back to hospital several times, it took that long for somebody in her circle of friends, in her family, and clearly there was history there with the hospital. They knew this woman over a very brief period of time, relatively speaking. Even with that intense activity and watching her, it was very still hard to deal with the alcohol that was part of the problem, or the major part of the problem.
And oftentimes it may not take a huge amount of alcohol, but alcohol in combination with drugs and alcohol in combination with over-the-counter and the other health issues may cause the person to decompensate very, very quickly. And so, our sort of the social perspective of somebody with an addiction is somebody who's drinking, lots and lots of alcohol, or they're on the street drinking, they're drinking from a paper bag, a brown paper bag. But with older adults, there's less of a tolerance to alcohol, and so they can end up in emergency departments with alcohol-related falls and not being detected because there's no blood alcohol level. And those are the folks that we often end up seeing in treatment. And our program is quite a bit different than mainstream programs because you don't really have to admit that you have a substance abuse problem in order to access treatment, because we're looking at all of the issues, not just the alcohol piece. So it's more often the norm that we see this sort of profile of the older adult ending up with multiple hospitalizations, sort of the frequent flyer. Again, it's alcohol, drug interactions, and oftentimes falls.
So I've got a neighbor who may be elderly. I have a family member who is in that situation, and I think everything's fine. What should I be looking for here? Because there is the distinct possibility that she likes her sherry before she goes to bed, and I didn't think anything of it. And I'm not really thinking much about the medication.
And you may be the lovely neighbor who's purchasing it for her.
Exactly. Yeah, I'm enabling. What should I be looking for here?
Well, again, as I said earlier, how do you know when somebody has a problem? Grandmother's having a bit of sherry at nighttime, but if she's not having any sort of obvious problems, then it's not a problem. But when she starts to fall or becomes incontinent, is forgetful, not paying bills, spending money on alcohol, not buying the groceries and so on. So those are the kinds of things where you see people spiral down very, very quickly. And so if you, on a community visit, I go into the person's home and I might look and just around in the environment and see, are there lots of empties visible? Is there, in the fridge, is there more alcohol than there is food? Is there hidden bottles hidden here and there? Because there's a great deal of shame and stigma associated with having a substance misuse problem, and generationally, especially with women. You know, maybe a person who's grown up with prohibition, and so you would never, ever in a million years admit that you were drinking. So socially, it would be quite unacceptable. So for older women, that may be hidden. So I'm looking around for the empties, and also other signs and symptoms, the physical appearance, jaundice, you know, the color of the person's skin, bruising at sort of furniture height, a lot of times flu symptoms. You know, you're calling up a grandmother, I'm coming over to take you out to Tim Hortons. Oh no, I can't, I've got the flu, dear. And what's the flu? And sometimes the flu is withdrawal from alcohol. Sometimes the flu is not being able to keep anything down the next day, or shaking because of needing to have another drink. You know, having the hair of the dog that bit you. That's the one thing that, when someone becomes very tolerant to alcohol, that if they're very ill the next morning, they may find that they need to have a little bit of a nip the next morning in order to deal with those symptoms. And so those are some of the indicators that might tell us that the older person's running into problems.
Dr. Meyer, with everything that's going on, I know my mom and dad are healthy, and Dad's been 20 years retired now. They are very active. He's got his workshop. She cleans the house within an inch of its life every day. So that there's nothing going wrong there. But I know at any one day I might get a phone call and say that they are not well. But I also know that if there was something wrong with my mom, first thing she'd do is she'd be on the computer. Is the internet helping you or hurting you? Because I know she's got all the answers now that she's got access to the internet.
Well, sometimes we do find our hearts sink a little when people come in with a sheaf of printout. And sometimes, with all due respect, when they come in with a sheaf of printout from the pharmacy, because there's all this information out there, but what really matters is how it actually relates to you or your parents. Mm-hmm. And you have to kind of interpret what's out there in relation to the individual. So I think I'd go back to an earlier part of your question, which is having someone accompany you. And I think that is really almost essential. Where I work, we have quite a lot of older people who have nobody. But sometimes it'll be the occupational therapist who may come, or the visiting nurse. And of course we do some home visits. But it's really important, I think, to have somebody with you, if not to make some notes, because when you're dealing with diagnoses, when you're dealing with all the bags of medication that come in, you really need to have a lot of your mind on a lot of different areas. So if only to have somebody who can actually record for you. But what we find is really essential is, if possible, to have somebody who provides what we call collateral information, who has a perspective on what's going on. And to have this trusting relationship
When
is
you,
often...
sorry, but when you say perspective of what's going on, that's beyond the medical needs? That's how they live their lives, the lifestyle, more a broader picture?
Yes, yeah. I think so. And a couple of things that haven't been mentioned, which seem to be very down to earth, are how well nourished are people and how well hydrated are they. So food and fluids are essential. And if you're having some alcohol, then that provides you with empty calories and may, in fact, interfere with your nutrition. If you're kind of housebound with pain and you're taking analgesics, narcotic analgesics, then you dry out fairly quickly. And the other class of medication we haven't mentioned, which you think, well, people don't become dependent on, but in fact they do get very used to taking, are the neuroleptics and the antidepressants. And these may help with symptoms, with target symptoms, but they also do need you to be as well nourished and well hydrated, to have regular meals and regular fluids as well. So going back to having somebody there who can sort of round out some of the bigger picture, because we're looking at the person. I think the other piece is to amplify what Marilyn has been saying, is that we don't ask people, do you drink? Because there is this shame, there is this stigma, and a lot of people don't drink alcohol. As you say, they may have a brandy at bedtime and a sherry for their appetite, but they do not drink alcohol. So that it is really looking at people's context, what's happening in their lives, what's the changes and losses particularly that may be going on. And in fact, alcohol is the most frequently used antidepressant. People often use it to help their spirits, but in fact it's a chemical depressant. So there are a lot of different features, and going back to the internet may give you some information, but it doesn't necessarily say how it will pertain to you as an individual.
Yeah, Dr. Becker, I think as we, the baby boom gets older, this is just going to be a more pronounced issue for a lot of reasons, because the information is so immediate, and this will be a generation that will have thrived on Wikipedia. So this is going to compound the issue. Is the system, and is what, from your view here at St. Hilda's, are we ready for this? Because if we're not, we're going to have if we've already got some chronic problems with addiction among seniors, we're going to have some real serious problems in the next 10, 15 years.
There actually are two problems we're skirting around. The topic is addictions, but I think the better topic, and we should talk about it, is polypharmacy. Addictions are skirting around the edges, or getting deeper into it around the edges. But one of the things that Dr. Meyer commented on about the increasing use of antidepressants, and as the medications are becoming more effective and the doctors are more comfortable with them, the side effects are lessening as we get better meds, is that we're prescribing these more readily. And so it's much more prevalent now to have to be moving towards polypharmacy in an area to a degree that perhaps we weren't before. And I think Constantine hit it on the head, and I was remiss to not note that. Your best friend is your pharmacist, and if you have a pharmacist who's engaged in your care, if you're not going to multiple pharmacies, and the science of it now, I don't think they're all connected yet, but they will be soon, so that any pharmacist should be able to know if you're at least receiving ODB medication, that it's all centralized and they'll know what you're taking. So I think that's a terrific response to controlling the polypharmacy and the side effects that are interacting. One of the things that I'd like to point out to everyone is that a really potentially risky issue is a situation where an individual is taking a medication. It goes back to the doctor. Doctor decides to renew the medication and puts, doctor, give me some renewals on the prescription so I don't have to keep coming back. So the doctor may prescribe 6 months if it's a stable drug, like something for blood pressure. And then 2 months later, there's a problem, and the physician says, stop that drug, I'm going to give you something else. And the something else comes with another 6 months of renewal. And so when somehow either the patient or a third party takes the medication back to the pharmacist and goes for renewals, well, the pharmacist will note that there's 4 renewals left on the first drug, and so renews it. And there's 5 renewals on the second drug, and renews it. And so the person is now, unbeknownst to anybody, taking twice as much medication as the doctor thinks they're taking. And somewhere in there's fault, but it's vague, especially as you get older and you may not be really aware of what you're taking. Patients say, I take a little white pill and 2 little blue pills, and that's the extent of it. And believe me, as I'm starting on my polypharmacy as I'm getting older, I am talking about it, 2 little white pills and a big green pill in this. So, and I'll never forget Dr. Zerzito's picture that she has of a big jar. Is that your picture? A big jar of pills. You just picture it's like on Howdy Doody show with all the different, M&Ms, and this was taken out of a patient's home who had, I think, collapsed or something. So polypharmacy is a huge issue, and around that, of course, is addiction. So if they're taking alcohol and the doctor may not know it or does know it, and it interacts unknowingly, One other thing I'm really concerned about, and that is the issue of chronic pain. We've talked about it, mentioned it a couple of times tonight. When I was in training, there was no chronic pain. You never treated a chronic condition with an addicting drug. That was an edict. You were taught this. And I don't know what's happened. There's, I think, a schism between the young doctors and the old doctors. You know, the joke, at some point a patient will come to you as when you're a new doctor, and they'll say, this isn't a joke, on a side joke, and they'll say, "Doctor, I've decided to change doctors because I wanted to go to a younger doctor." And you feel very proud because you figure you have all that knowledge, the new stuff, and the old guys don't know anything. And at some point in your career, the patient will come to you some years later. A new patient comes and says, "Doctor, I've changed doctors. I've decided to go to an older doctor." Because now you're proud because you have all that wisdom and knowledge. There is a difference between how younger doctors are prescribing medication for pain or diagnosing pain and the way older doctors do. So I think there is an epidemic of, in my opinion, overprescription of narcotics and all sorts of drugs, particularly narcotics. You know, oxycodone, no one took that unless you were recovering from an auto accident in the first week or two. And yet people are taking it chronically, big doses.
But, what I'm hearing here, though, is when we start to talk about addiction and dependency in the context of healthcare, as opposed to the crack addict who has it's addiction, or somebody who's got a food addiction, it's a different kind of thing. This was all intended for their health and their well-being, and all the intentions were right to start with. No matter whether you thought the doctor was too young or too old, or you know, whatever the case may have been. The point was here, everyone stepped into this environment first and foremost with a view that it was to be trusted.
But the environment has changed.
Well, I agree, and I guess what I'm getting at is, to me, as I'm listening to you, it's becoming you're not encouraging me. It's becoming all the more difficult then to sort of come to a consensus, or a sense anyway, to say, this is how we can first recognize it and deal with it. This has become far more complicated in this hour for me than it might have been if someone had a heroin addiction and were living on the street. As bad as that would be, living on the street is not a healthy environment to begin with. I'm not walking into that environment and getting into crack or heroin or cocaine thinking it's good for me. I started this journey to the doctor because it's supposed to help me. It's supposed to help my chronic pain or my blood pressure. So there is no poor intention here generally. The system is built to help everybody. Wow, how do we get past that, deal with the trust, because as soon as it breaks down, everybody feels badly, but we've got people who are addicted and have some serious chronic problems.
May I address that?
Yes.
Okay. So I think that you're right. I think that most physicians, all the ones that I know, all adhere to the Hippocratic Oath as closely as they can, which says, first of all, you try and do no harm. And indeed, when a patient comes to you and has pain, we use whatever medication or tools we have at hand to alleviate that pain. So we don't anticipate that a dependency will occur. We don't anticipate now with the opiates, or if someone suffers from anxiety with something that alleviates anxiety to some extent. No one foresees this, no one promotes this from the medical profession, but there are some individuals who do develop more dependence, so initially, let's say the sleeping pill, my partner, my husband just died, I need something to help me sleep. So you say, okay, you'll take this little pill called Zopiclone or whatever. It's a small dose, and I only want you to take it if you absolutely have to. But chronic sleep problems are common in older people. And so they come back and they say, "Doctor, I want some more of that medication." And then you have a relationship with this individual, and sleep is important, and trying to wean yourself from this medication, which was meant to only last a very short time, is it's very difficult to do that.
So when does the flag go up, though, for that physician then, when that individual comes back and says, "I'm still not sleeping," or "I still need that medication"? And if the original marching orders were, take it for a short period of time or only when you need it, and that could mean something to everybody differently in this room, when should the flag go up and say, "Hey, we got to review this"?
So, then it depends what the relationship and the conversation you have with the individual, your patient who trusts you, right? So you say, "Okay, we're going to go on a different kind of treatment for your sleep. I want you to walk a mile every day."
Next doctor, probably.
And that's what
That's the
happens,
problem,
you
sure.
see. Then, "Okay, doctor, you
Those
just
are the realities.
you just want to give me the sleep hygiene, Bible, and tell me that I'm supposed to exercise, and tell me that I can't eat before I go to sleep, and tell me that I'm to stay away from alcohol, and tell me all these other things, that my room has to be nice and quiet, and not too cold, not too warm, that I can't watch TV before I go to sleep." All these really good strategies for trying to sleep. And she says, "Okay, doctor, I'll see you next month." And then you find out that she's gone to Dr. Becker, who says,
Oh,
"Okay."
I'm a tough son of a gun, I'll tell you. I wouldn't. See, here's my question. When does care
Yes.
become concern?
Right.
When does concern become control? And when does control become unwanted control? And that's when the patient leaves you.
We're back to art versus the science.
Art
of
versus
this.
science.
Sure.
And you obviously you care because you give them something for their pain, as opposed to Becker saying, "You don't have any pain, you're okay." Or that's hard to do. Moreover, I would say you don't really have a sleeping problem, because people who are 85 may only need 4 hours of sleep at night as compared to 20 when they were 1 year old. And so if you go to bed at 10 o'clock and you're up at 2, you've had your full night's sleep. Okay, so I may show care by trying to talk them out of taking medication, or I may show care by giving them the medication. And then I become concerned about their taking too much. And so I guess the next step is to inform them of your concern and tell them the risks and the problems, and this is not good for you. And then they say, "Well, I still want it." And then you start to control. And that's not a pleasant place to be.
I just want to come back to...
And then, thank goodness for the psychiatrist.
Well, I just wanted to come back to some of the stuff that we were talking about a little bit earlier about that which isn't prescribed. And Dr. Meyer, you were talking about sort of the over-the-fence remedies. I remember when, I hate admitting this, when I was a kid, I had eczema. And we spent the summers at the cottage. And my grandfather's answer to the eczema was to break the blisters on the balsam tree and put the gum all over my arm. And it made a hell of a mess. And I thought, he's nuts. This isn't going to help me. 2 days later, I could go swimming, everything else, it all sealed it, eczema dried up and it went away. If I'd have gone into my doctor's office, he would have given me salve, or he would have given me something else. In that case, I'm lucky it was something that worked, and it was only the balsam tree gum. But I don't know what the next remedy was with the balsam tree gum was for whatever ailment. But we do that all the time. We do that again. It's well intended. How do you guys stay ahead of that curve? Because it's hard enough to manage it with the pharmaceuticals that are all documented, they're all tested, they're all researched. How do you stay ahead of that? Plus what goes on in a market or over the fence?
Well, I think, as Dr. Zozito has emphasized, there are non-pharmacological approaches. And sometimes one of the really difficult things is to persuade someone that the answer doesn't lie in a pill. I think, as Dr. has been saying, the question of control and, you know, the old doctor's orders is really not a very helpful way to continue a relationship, because one wants to try to work with the patient. But in order to do that, the effort really is to try and understand what the patient understands, what the patient really thinks the issue is, and really to ask too what the patient thinks will help. You know, sometimes you get the answer, well, you're the doctor, you ought to know. But if you can pursue that a little bit more, you get into other layers of the history, other layers of people's concerns. And it's a question of trying to work with. Sleep and pain are two huge issues. People are often referred to psychiatry with depression, and depression is a huge spectrum, from a real severe disorder to part of the human condition. We all have down days, we all have bereavements and losses and grief, and it depends on, as Marilyn said earlier, how much it affects functioning. So trying to understand where people are in their lives, what they think is happening, and also what their beliefs in what medication will do is very important, because medications don't just hone in on a particular area, they do lots of other things. So to try to deal with these issues, I think really trying to understand where the person is at that time. I remember when I was a medical student, the sort of short summary was, why does this person present in this way at this time? And sleep and pain are two huge areas that are very, what we call multifactorial etiology. There are so many different factors contributing to what's presented as pain.
But that summary still holds. Why do they present this right now may be different than why they presented 2 weeks ago. And I'm assuming that your view of it and perhaps even the treatment and prescription might be different.
Yes. The other thing that I wanted to mention about pain is often we can continue with a medication but actually use less and be more effective if it's taken as is more effective, which is often taken regularly. So often people wait until the pain is excruciating and they can't take it anymore, and almost nothing, you know, sort of anesthesia is going really to make a difference at that point. So a modest amount regularly while you're trying to understand the causes of the pain. And I say causes because, again, stress, anxiety really heighten the experience of pain. And so you may be really looking at other aspects of in life rather than just looking at the presented symptom.
So we've got about 10 minutes or so here, and I really kind of want to get to two things. I want to talk a little bit about, I think, what we've all sort of touched on here with either the questions or certainly with the answers. And then I want to turn this around on each one of you and give you the opportunity to tell me how you are going to deal with the doctor in your life who is either trying to prescribe for you or for an elderly person in your life. But first, I just want to kind of come back, Marilyn. It doesn't matter, how we come at this issue of dependency or addiction, or really what's important here, beyond understanding the systems and the medication and how one affects the other, it is vital to establish relationships here. So that the people who are coming for treatment, that the people who are in need of medication, that both the provider of that treatment and the individual coming forward there has to be some kind of a relationship that really is going to be vital to the long-term benefit of everybody involved and the health and well-being of the individual.
And when people are referred to our program, the first thing that I need to do as a therapist is to establish rapport. So if they're not engaged in treatment, if they're not interested in seeing me, then I might as well pack my bags and go home. So that's really very, very important, is to establish a rapport and a trust. And especially if there's someone who is dependent on medications or on alcohol or other drugs. We haven't even talked about marijuana, but that's also out there. To help the person to look at ways to make healthy choices, and to look at ways to cut down. And I appreciate what Dr. Meyer was saying in terms of medication, right dose, right time. And certainly taking it regularly, but with alcohol and other drugs, to look at ways to help the person to cut down using harm reduction practices, so that they can function better and be able to remain in the community. Because an older adult that has alcohol or other drug and health problems or mental health problems, they can get very sick very quickly and end up inadvertently in long-term care. And when they end up in long-term care and they've got the right care, medications, the right medical care, lots of adequate nutrition and so on, and in the absence of alcohol, they suddenly become that much better. And they may even not need to be in long-term care. So it's important to establish a relationship with the person and look at what are some of the healthy choices that they could be making in order to cut down or stop the substance, without really sort of, this, we're not there to point the finger or confront people about it. Look at what are the solutions to the problem.
Constantine, when we talk about the pharmacist role in that, can the system, I know we all say we need to develop the relationship with these people, but is the system built to do that?
I think the system is changing towards more what Marilyn was speaking of, and in pharmacy as well. I think that as a pharmacist, I have to move more and more towards speaking to my patients, having conversations with them. We talked about information. We talked about information being readily available on the internet. I think that a pharmacist's role is even more critical today, with really lack of time that a lot of physicians do have to engage in conversations about medications in detail. I think that we need to use specially trained technicians to do the filling process, to do the counting, to do the pouring, to do the entering of prescriptions into the computer. And I think the pharmacist, it's a great opportunity to really step up and be a leader in this area, and to make sure that everybody understands what their medications are for, the proper use of the medications, in conjunction with all of the other over-the-counter products, the herbal medications, drug interactions, polypharmacy, all of these things. This is where the pharmacist really needs to move his or her practice towards. It's more of a consultant, it's more of a source of information, and a person who can sort of help the person sift through the tons of information that are available in the newspapers, on the internet, from friends and neighbors, and to feel comfortable to come and ask the pharmacist, my neighbor gave me these leaves to rub all over my arms, what do you think? I trust my pharmacist to ask him or her that question. And in that way, I believe that in conjunction with, like I'd mentioned before, I'm sure anybody here who's presented with 10 or 12 bottles with 3 months supply of various types of medications put in front of them, myself, I didn't even know how I would deal with that. The way I would deal with it, I believe, is smaller quantities at a time, and when you're getting into polypharmacy, which may or may not be necessary, but sometimes people do need to be on 8 or 10 or 12 medications for multiple issues, that pharmacies need to be used to get into special packaging, to help manage medication and not overwhelm people with bottles and with lack of information, with looking at this white pill and having no clue what the name of that medication is, let alone what it's supposed to do. And I think by pharmacists getting more involved in all of these roles in their community, if we're talking about the community as a retirement home, if we're talking about someone's coming up into your pharmacy that lives in the community, I think this is really where pharmacy can help. And I think it's possible. I don't think it's a losing battle. I think we all have the opportunity to
Well, I think it's become necessary. We have questions here. We've got a few minutes, and do we have a mic in the room that we wanted to, we've got questions over here. Was there somebody that had a question? Well, we're looking for questions in the room. This gentleman here has got a question. And I want you to make notes on how you're going to come back and your 3 bullet points.
Perhaps Constantine can help me on this one. I'm a client of his and very impressed with the care he gives to the elderly.
Thank you.
Isn't there another thing added to the mix? And I don't think I can hit the word, but it's a kind of pills or medication that you get from this new doctoring of, help me on that. But they're not doctors, but they have medications that they provide.
Oh, you mean like alternative or naturopaths?
That's,
okay.
Thank you.
There's differing opinions on those type of alternative or natural medications. My take on it is that as long as the person using these products is educated as to the safety of using that type of product, is educated, their whole profile is looked at in terms of that there are not going to be any interactions. That also a big thing I find with using alternative medicines is to be careful not to turn one's back on traditional medicine and pharmacy, to realize that really these products sometimes can be used in conjunction with your prescription medications, but oftentimes not instead of. So if we're going to use something to, say, help with cholesterol, and it's something a person really wants to try, that it doesn't mean that it's necessarily going to be a substitute for, say, your Lipitor, but it might be enhancing your Lipitor. And that a discussion has to be had with the naturopath, with your regular doctor, and again, even with your pharmacist in terms of tying all of those things together. So I think as long as it's safe and it's a healthy decision and you're not going to do yourself any harm, as long as you have the information and that you include your whole healthcare team in that decision, I think that there's no problem with that.
Are there any caveats there that go with some of what may be sort of a naturopathic treatment? There are issues with that may not be standardized. There are questions around that in terms of getting this from this source is one thing, getting it from another source, there may be variations there that...
Absolutely. You have to be careful. If there isn't any sound science behind something, I mean, I'm trained with the scientific method, which means that there has to be some sort of proof to back up that something is going to do what someone says it's going to do. And if there just isn't that information or that proof or those studies out there, then you do have to be a little bit careful that you're not putting yourself in a guinea pig sort of role where you're going to be part of that ongoing sort of study by taking something that maybe isn't exactly proven. But again, someone like myself can only tell you what we know about such a product. There's a lot of unknowns about these products. And I have no problem saying the words, I don't know, because I feel that if I don't know something about a product, then it's something that you have to approach with caution, something I have to approach in terms of recommending it with caution, because I carry some of these things on my shelf. And, I don't make any money by not selling something. But if I have any doubt that I don't know if that's safe for you and your mix of 10 or 12 medications, I'm going to tend on the side of caution and say, well, maybe you shouldn't do this, because there just isn't enough information for me to be confident that it's going to be 100% safe. But if there is enough evidence behind a product and it is going to be safe, and it might give you some peace of mind, or it might actually help in some way in addition to whatever else you're taking, then we approach it with a risk versus benefit type of process. So,
Dr. Meyer, did you have something you wanted to
Just
add to that?
wanted to add, something like St. John's wort, which is very frequently used for depression these days, can react adversely with other medications and have an effect on bleeding and clotting of the blood. That must be something that you see.
there's so many examples like that, and again, the role of someone like a frontline pharmacist to have their customers, or like I like to say, my patients, trust to come and ask me anything about any product. It's when you take something, say, that your neighbor suggests that you take. And like somebody else mentioned before, everybody's individual. Is it the right thing for that individual? It's something that, a lot of the general public, they don't think about the individual, that if in general they've heard that this is good, then one might think it's good for everybody, and that's not always the case. You really do have to look at it as a case-by-case, individual-by-individual basis when getting involved in even something like natural medicines, where you can see that there can be a lot of different side effects and interactions, because a lot of these natural medications this is where pharmacy began, and this is how drugs have developed over the last couple hundred years. So if we go back and use so-called natural medications, I mean, a lot of them actually do have medicine in them, and they can have adverse effects on other medications and other medical conditions. So it is really about information, and to be comfortable asking and knowing that you're going to get an answer when you do have a question about something like that. And I always encourage all of my patients to ask, because we have access to the information and the computer and all kinds of resources if we don't know the answer off the top of our head even. So, ask.
Let me now we're going to turn this around. You've had time to think about it. If you are now in the place where you are the consumer, you are the advocate for someone else, you are the patient who finds yourself in that place where you need to ensure that you're getting the best result, the best answer for your medication or for the elderly person in your life, the loved one, whoever. I mean, these folks are all going to deal with this at some, we all will. And I'd be curious just to hear what, the 2 or 3 things that each one of you would suggest. This is how you would approach it. Dr. Zorzito, do you want to start us off? It's not easy, eh?
It's not. I mean, going on the internet is always not the right approach, because it's overwhelming, the amount of information. But how do you seek expert advice? I mean, if you needed an orthopedic surgeon, how would you seek expert advice on that? You need a knee replacement or whatever. If you have problems with pain, there are layers. There's the family doctor, and if that doesn't work, usually there's a referral network in place to a greater level of expertise. Sometimes that's the approach. Sometimes calling the college, the College of Physicians, and they have a list of experts in certain areas.
There's no
it's very
shortage of
hard.
resource. It's trying to navigate that. I guess sometimes that can be a little.
It's trying to navigate,
Yeah.
but when it deals with elder issues, there aren't as many so-called experts out there as we are going to need.
Dr.
need
Becker,
right
what
now.
advice would you give somebody then to, that sort of faces that? And again, my mom and dad have the little tray of medications and mom's telling dad and dad's telling mom how to make sure they take them. What would be your approach to that, you in that situation, to make sure that you're getting what you need, and advice you can give to this room?
Like you said it earlier, Dave, it's about relationship issues. I think that being a primary care family physician, I'm going to advertise that. I think you need a good family doctor that you trust. That's the beginning of it. And it's a front-end loaded situation. Whether it's a geriatric specialist that you're being looked after by, or a surgeon, it's a front-end loaded. You choose the doctor after deciding that this is the doctor I want to look after me, and then you follow the advice of that doctor. That doesn't always work out. It's a bit idealistic to say that. I think your best friend is going to be a family physician, the primary physician that you deal with, whether it's in an assisted living home or a nursing home. You don't always have a lot of control necessarily of who that person is. Once you start, they may change on you. My thoughts about if I had to go to somebody and they were telling me what I should and should not take, once I've decided this is the person I want to trust, I think it'd be harder for that person to get me to stop drinking alcohol or stop eating chocolate in my case. Whether or not they said it's good for me or not good for me, I think I'd start to follow my own thoughts on certain things over the counter, if you want to call it that. But in terms of medically prescribed medication, I think you're really at the not the whim, but you have to follow what your family physician says, or what your primary doctor says, or your heart doctor, or whatever it is.
So that
I think something's showing up tonight very importantly with Constantine. I think the pharmacist is one of your best friends, and I think we're underplaying that card very, very strongly.
How many folks in the room have taken advantage of that relationship with a pharmacist, made the point of sort of asking them more and more, getting them more involved in their, still a few that don't, eh? And there's a growing number, and I wonder if that's not just because we have this sense that we don't want to step outside that patient-physician relationship yet. Dr. Meyer, that's a difficult thing to break, that habit. We started by saying this was about trust, not that we don't trust what Constantine is saying or that it's an important part of it, but it's a relatively new thing to be able to say we have nurse practitioners who can do different things, we have the pharmacists who can be involved. This is a slow process. It's a big beast of a machine. How do we break through there and let people know that it's important that they do have not only the resource, but the permission, perhaps the responsibility to knock on Constantine's counter and say, hey, I need that help?
I think there are several points in that comment. One is the importance of there being a healthcare team, that there are different healthcare professionals with different skills and experience, and the important thing is how we communicate together. I think in psychiatry we've kind of had a team approach for quite a while, and certainly the pharmacist has always been a crucial part of our inpatient teams and increasingly the outpatient teams. It's really a question of resources, of the number of people, but the communication is important. I agree with Dr. Becker. I think having a primary physician, and I know how difficult it is because we have an increasing number of people who don't have primary physicians, is a really important thing. I think the other is to be prepared to really respond to the doctors or the primary person, because sometimes it is a nurse practitioner in health centres these days too, to the inquiry. And one of the things that helps in the harm reduction model really is what I've called to the residents a sort of spiral approach. You begin with what seems to be the presenting problem, and then gradually include more biological, medical, psychosocial, and other parts of the context. So really, again, it's a collaborative effort with the physician. And the other, I think we said three things. The other important thing, I think, is not to kind of make your own diagnosis up front, but be prepared to have this sort of inquiry. I mean, for example, chest pain may not be heart. people so often say, I've got a heart problem, but in fact it may be something quite different. And in psychiatry, we find with depression, for example, it can present in so many different ways. It can present with chest, with digestive, with joint pain, with all kinds of things. So not to make the diagnosis yourself, but to give what the problem seems to be, and then to collaborate with the inquiry. And it needn't take a lot longer with a skilled physician, but it's really important to have that history before you move on. It's a first step in any kind of diagnosis or plan of treatment.
Marilyn, we've talked about the need for the relationship and how important that is. I think what we heard from Dr. Zorzito and Becker and Meyer is that all good advice, not just in terms of being able to manage medications and deal with the dependency or addiction issues. We're talking about really sound advice in healthcare generally and how we should approach the system. I'm curious, when you talk about dealing with the treatment of those who are facing addiction issues, how much of that is actually a symptom of them having a difficult time navigating their own healthcare issues?
Absolutely. That's a huge problem, and that's what we at COPA do with our folks in treatment, is to help them navigate and perhaps even to go to the family doctor and provide the collateral information that Dr. Meyer was talking about, because there's not just one issue that we're talking about. It's not just the substance use, it's the pain, the depression, and so on. And so it may be that we're talking about some of the resources out in the community that the family doc may not know of, and to make referrals to geriatric day hospitals where there's an interdisciplinary team, and looking at helping the person get a bit more mobile, because with alcohol use, it goes to the brain or goes to the liver, and sometimes people end up with mobility issues, they end up with memory issues, depression, other physical health issues. And so oftentimes a geriatric day hospital program can help people get back moving again, providing physiotherapy, occupational therapy, while and also there's a geriatrician and social worker and so on. So a collaborative approach, an interdisciplinary approach to help people get back on their feet again.
And Constantine, let me turn it around. I want you on the other side of the counter for a minute here, okay? Now, you're the one that's going to actually be the one who needs to get what you need in terms of information. And I know that the medical folks, the doctors and the nurses in my life sometimes have the hardest time actually navigating the system, because to some degree they take things for granted when they ask a question. I've seen them do this in the care of their parents or whatever. They are asking what they think is the right question from their own expertise and their perspective. But it can get lost in a hurry. I'm going to ask you to cut through that and give me sort of the three. I think your advice is great about making sure that you and I have a relationship to understand what my pharmaceutical needs are and the history is there. Two other things that help me navigate beyond the counter at your pharmacy that make that care more effective, maybe enhance that relationship with you.
Well, someone mentioned something about a team approach. And if I'm on the other side and knowing what I know, of being an integral part of the system, I would highly, highly recommend that you look at it as a team approach, and that the people that run the team is the patient and your family and or your friends. That's where you have to start. You have to make sure your family, your friends, because not everybody has family members around. You can always turn to a good friend or a neighbor, and you need to look at yourself as that you're in control of that team, and that everybody else, from a strong family doctor or even a family practice type of clinic, where you have maybe a set of a few doctors that cover for each other, that you can go in and trust that when you need something, that you're either going to get information, you're going to get the right service, you're going to be seen when you need to be seen. And In addition to that, to have obviously a pharmacy team member that you trust as well and that you stick with and stay with one pharmacy. So, you know, one family practice or one family doctor, one pharmacy, and you're the head of your team, and you really have to be either your own advocate or you have to use the family or friend to be your advocate if you can't be an advocate. And you really do have to sort of that, you know, squeaky wheel gets the oil. I mean, it really is true in this system, is that you do have to probe, you do have to ask the questions, but if you've got a whole team, a whole sort of group of people on your team that you trust and that you can talk to and get information, I mean, I think that's really the key to get through the system the way that it is now. And, you know, whether the system is going to continue to allow that, I'm not sure. I hope so. I hope that the politicians and the decision makers really look at that sort of team approach as the way to go about it. I think they're moving in that direction, where you have patients working with the physician team, and all of those people are working with the pharmacists, and they're working with nurses, and I think that really is the way that you know, we're gonna win. I mean, because that's what it's about. It's about health, good health, and information, and being able to get access to all of that. And I think that's the way to look at it.
Well, as you were saying that, there's a lot of heads in the room that are kind of nodding in the affirmative, so I think you've sort of touched on a nerve here. There's one other thing I would add, and two things. First is that what St. Hilda's is doing here is kind of an important opportunity for all of us in the room, and certainly those who are watching, to be able to take advantage of all the good advice and the expertise and the anecdotes that you're able to bring, just to sort of illustrate not only that there is an issue, but that there are a variety of solutions, that the important thing is about relationship, that the important thing is that everybody in this room to some degree has a responsibility, but also can take charge, as you said, Constantine, in terms of you are your own advocate, and make sure that you've got your own team as well as your healthcare team. But the other important thing to remember, folks, is this is an election year, and healthcare is going to be a significant issue when we elect the next government in Ontario in October. So that the folks here at St. Hilda's are doing this. They are to be commended for bringing this up, to being able to make this an issue. It's important, obviously, in this setting, but it's important for all of us. So thank you all for taking the time to talk to us tonight. Can we give these folks a round of applause just for all that? And we do appreciate it. Thanks for coming tonight.
Good evening. My name is Doug Campbell from the board of St. Hilda's, and I sincerely hope that you enjoyed the discussion as much as I did. So we'd like to thank our panel guests, Dr. Becker, Marilyn White-Campbell, Dr. Meyer, Constance Shishi, and Dr. Zorzito, and of course our moderator, Dave Trafford.